Welcome to the webinar being organised by the HRB Primary Care Clinical Trials Network. I will now introduce you to our presenter today, Professor Liam Glynn. Liam has recently been appointed as the new Professor of General Practice at the Graduate Entry Medical School, University of Limerick. Prior to this, Liam was a Senior Lecturer in NUI Galway. He is also a Rural GP in Ballybohan, County Clare. Liam originally graduated from Trinity and was appointed a HRB Cochrane Fellow in 2007. He is the lead author of Cochrane's Systematic Reviews in Hypertension. He has an extensive history in primary care research, and his main research interests include preventative medicine and technological solutions to healthcare. Liam, thank you very much for delivering our webinar this afternoon. I will now hand over to you.
Thanks a million for that, Martha. Can I just check that you can hear me okay? Can you confirm?
Yeah, I can hear you perfect, Liam, yeah.
Great, okay, super. Right, let's get going. So thanks for the introduction. Half of that I didn't recognize, but nonetheless, it's lovely to hear those kind words, and delighted to get the opportunity to give this webinar today. Right, how do I turn on to next slide? There we go. So the webinar is entitled Blood Pressure Control, Missed Opportunity or Holy Grail. First of all, this is my first time giving a webinar, so please excuse me if this is really clunky. Hopefully it won't be. What I hope to cover today is I want to talk about hypertension risk, diagnosis and monitoring. I want to talk about just allude to the changing landscape, because there have been a new set of guidelines published by the American College of Cardiology and the American Heart Association this year. Also, our landscape in this country has changed significantly with financial incentivization around ABPM use in Ireland. And I suppose just a word of warning, we will talk a little bit about pharmacology, but I'm assuming that most of you know the pharmacology, to be honest with you. So I'm not going to spend too much time. I'm actually going to talk a bit more about the non-pharmacological interventions that we can get involved in terms of managing our hypertensive patients. Now, please, I'm looking at the Zoom chat, so if I'm not making sense or you can't hear me or I'm speaking too fast, then just please type away and let me know, and I can adjust according to your needs. Okay, so hypertension risk diagnosis and monitoring. Why is hypertension so important to us? Well, first of all, just this year there was a really interesting global article published in the Lancet naming hypertension as the leading risk factor for global disease burden. And not only that, but it's largely managed in primary care where we all work. So it is a hugely important public health problem, particularly when you think about it in terms of the outcomes, the negative outcomes associated with it, i.e. myocardial infarction and CVA, and I suppose the implications of those for patients and also for our healthcare system. And also the other thing we know is that it's readily preventable by blood pressure reduction. But despite this, blood pressure goals are achieved in only, I mean, the rule of thirds tends to apply, but if you look at the figures, 25 to 40% of patients only who take antihypertensive treatments achieve blood pressure control. And interestingly, this is a situation that has remained unchanged for the last 40 years. So I'm hoping that by the end of this webinar, we will talk about some of the new strategies and new developments that hopefully will change this. But this is, when you look at the research on it, this is unfortunately the landscape in which we operate. So I'm hopefully going to challenge people to think about how we all may be able to do things better. So there's nothing like starting with a case. So I'm going to talk about this case a little bit as we go on. So Mr. P is a 43-year-old, and I'm hoping to get some feedback from you on this particular case. So please feel free to use your Zoom chat as we go along. So Mr. P is a 43-year-old married farm labourer with 2 children who's fairly active between his job and running after his kids. He's an infrequent attender to see his GP. He's no significant medical history. He went to a promotional event in a local shopping centre, was offered a free blood pressure check, and at the check he was told that his blood pressure was 139/88, and he was advised to arrange to see his own doctor. And he was sort of surprised at this because he thought this was a normal blood pressure according to what he knew about blood pressure. So the first question I'm going to ask you is, should Mr. P be worried in the context of this blood pressure check? So anybody have any thoughts on that? Yes or no will do, or yes with a reason, or no with a reason will do as well. Everybody's probably still munching their sandwiches. Okay, so we keep going for the moment. The answer is yes. I mean, Mr. P should be worried. Okay, we got an answer there from Shireen. Shireen is a researcher. She's a medical student from Leiden University, actually in Holland. She's not actually in Leiden at the moment. She's over here in Limerick. She's working with us on a project. But the answer is actually yes, he should be worried. And if you want evidence around that, then there are lots of evidence, but I'll particularly draw you to Lewington's article in The Lancet, all of 15 years ago now, which showed a direct linear relationship between blood pressure and risk of stroke and risk of development of ischemic heart disease. Once you actually get over blood pressures of 120, 130, and this is actually this linear risk that we're talking about is actually even more. Is if you look at these lines here on the chart of mortality and blood pressure, you'll see that it's even more significant, the risk, because the lines are more acute in younger age groups. So this is really significant. If you want this sort of quantified in terms of groups of blood pressure, you will see that as your increment of blood pressure increases by 20 systolic and 10 diastolic, your cardiovascular mortality risk doubles for each of those increments. So so going from 115.75 to 135.85 actually doubles your risk in terms of your cardiovascular mortality, and so on. So I suppose, and the newer guidelines, we're going to talk about them in a minute. The control they're suggesting is even tighter than we're actually used to. So let's just talk a little bit about diagnosis, because I'm just picking out stuff that's sort of new in the sets of guidelines that have come out recently, the American guidelines and also the NICE guidelines. So in terms of measuring clinic blood pressure, that's often something that maybe we don't do as well as we possibly could. So in terms of measuring blood pressure in both arms, if the difference in readings between the arms is more than 20 millimeters of mercury, you should repeat the measurements. And if the difference in readings remains, then you should use the arm with the higher reading for subsequent measurements. If the blood pressure measured in clinic is 140/90 or higher, then you should take a second measurement during that same consultation. If it's substantially different from the first, take a third measurement, and then record the lower of the last two measurements as the clinic blood pressure. Often, as is the case with home monitoring or as the case with clinic monitoring, we should be disregarding that first reading, because no matter how diligent we are in getting the person to sit down and relax, etc., white coat is still a big issue. So we generally disregard that first reading. If the clinic blood pressure remains 140/90 or higher, then we offer ABPM. Okay, so the advent of ABPM obviously is a big change in our own landscape, and particularly with the incentivization around it. And we should be using it more and more, not just to confirm diagnosis, but also around medication change and also around monitoring. The suggestion around monitoring is that we should be ABPMing everybody with a diagnosis of hypertension at least once annually. And then while you're waiting to confirm the diagnosis with the ABPM, you should carry out investigations for target organ damage and a formal investigation of cardiovascular risk. And, I'm not going to tell you to use Q-risk over Framingham, whatever. Just use one of the up-to-date risk profiles in terms of looking at cardiovascular risk. And the reason for that is we need to make decisions then around primary prevention if there isn't any end organ damage. So a question that often comes up is, well, what about home monitoring versus ABPM? Because obviously some people just really do not like ABPM. Some people can't tolerate it. Some people have a very erratic ABPM readings. And home blood pressure monitoring is something that I'm constantly suggesting to my hypertensive patients. I find it a really useful adjunct, because anytime somebody sits down in front of me with high blood pressure, I want as much information on that patient as I can. And home monitoring is one way to fill out that information. And it's not, the idea isn't that people have to do it all the time. It's just that they, hopefully, when they sit down with a healthcare professional, they can provide up-to-date data in terms of some recent monitoring that they've done. So we do know that home monitoring is a better measurement than clinic monitoring for the diagnosis of hypertension than clinic blood pressures, okay? But it isn't as good as ABPM. So if people can tolerate an ABPM, that is what they should have. But home blood monitoring is not a bad alternative to confirm the diagnosis if somebody can tolerate ABPM. So how do you do home monitoring? Well, you've got to ensure that for each blood pressure recording in home monitoring, 2 consecutive measurements are taken at least 1 minute apart and the patient is seated. That the blood pressure is recorded twice daily, ideally in the morning and evening, and that blood pressure recording continues for at least 4 days or ideally for 7 days. You discard the measurements taken on the first day, again, like we were talking about in terms of clinic measuring, and you use the average value for all of the remaining measurements to confirm the diagnosis. So back to Mr. P. This is what his ABPM looks like. So any comments on this? Anybody have any thoughts in terms of this particular ABPM and the profile of it? Okay, we'll let people consider that. And just as we're doing that, maybe I'll just use my mouse maybe to point out. So this profile, which is the daytime profile, what does that suggest? Anybody have any ideas? Is that normotensive or hypertensive? Okay, so somebody come on there? Hypertensive, yeah, very good. So we've got elevated we've got daytime hypertension, nighttime pretty much normotensive for nighttime, and with some associated dipping. So this is Mr. P's key information. Just to give you the full profile on him. Okay, so we've said his age is 43 because I'm going to be asking you a few questions about him now. We've got to make some clinical decisions about him. So he's 43 years of age. He's got, when we measured, he's got a BMI of 32, so it's elevated. He's actually got an elevated HbA1c as well. It turns out on his bloods, along with he's got normal EGFR, normal ACR, and you can see his lipid profile here. And his ABPM confirms that he's got an overall average of 138/85 with a mean for daytime, as mentioned, at a hypertensive level of 148/95 and a mean nighttime, which is normotensive. He's a normal ECG, normal retinal fundoscopy, and absolutely I agree, Kieran, it is reassuring that his nighttime dipping is preserved, and that's well pointed out. He's not on any antihypertensives at the moment. He's on no concomitant medications. Does have a family history, interestingly, as a lot of these people do when you actually question them closely. And when we look at his lifestyle, he's quite sedentary. And I suppose I often think, like I don't know about you guys, I often have these farmers who come in to me saying, sure, I'm going all day, you know, I have to be fit. But actually when we talk about exercise, which we will in a little bit, the definition of exercise is something that makes you breathless. And what we find nowadays with a lot of occupations, including farming, is that a lot of the time people aren't doing exercise in terms of that definition, as in they're not getting their heart rate up appropriately to get the benefits out of exercise. Because if your heart rate remains normal, i.e. you're not, you know, the intensity of the exercise isn't there, you don't get the benefits. So he's also a non-smoker, and he's also, he's got a high salt diet. So when we're looking at something like this, I suppose, you know, there's a few different things that we need to just think about what we're trying to achieve here. And I'm just pointing these out to you. A lot of you know these. And yes, I agree, Kieran. It is done from the back of a tractor in terms of farming at the moment. And I think this is the problem now. A lot of other jobs as well with the advent of technology have gone towards much more. You know, they've increased in terms of their sedentary level, as opposed to having a big exercise component to them. But anyway, in terms of, so let's just think about what we're trying to do with this patient. First of all, we want to make sure of the diagnosis. So we want to confirm the diagnosis, presence or absence of hypertension. The next thing we want to think about is whether he's any target organ damage associated with that hypertension. So you've seen his profile, so that's a question I want you to consider. Then we've got to evaluate the person's cardiovascular risk for lots of different reasons, but also to help us make good clinical decisions around them. And then we've got to also consider this idea of secondary cause of hypertension, because this is something that's thrown around a lot in terms of, you know, what is the incidence of secondary cause of hypertension, and they seem to be somewhere in and around 5 to 10% of case of hypertension, so they are worth going after. So what routine clinical investigation should we be doing? I'm reiterating these. I know a lot of you know them already, but let's think about, think about the end organs. It's the end organs that you really dictate where you're going to go looking in terms of your investigation. So certainly we're interested in the kidney because of the potential for hypertensive nephropathy. So we urine dipstick him. We do bloods in terms of his electrolytes and creatinine and his EGFR. We calculate that. We also are interested, obviously, in comorbidities, so we do a blood glucose and we look at his lipids levels, because if they are elevated, then we got to think about, is this somebody who's got that elevated cardiovascular risk who might need statins from a primary prevention point of view. What's the other organ we're considering, or at least we can examine for? Certainly hypertensive retinopathy is an important marker and seems to be picked up more and more. So that's something we should examine. And of course, we should do an ECG, because we're considering the heart also as an end organ and the potential for end organ damage there. So in terms of secondary cause, I just allude to that. It may occur up to 10% of cases. We should definitely consider it in younger patients, particularly those under 40. Or in people where their blood pressure suddenly elevates, so an accelerated picture, or those who respond poorly to treatment, which is the resistant hypertensive group, which I'll talk a little bit about in a second. So what signs are we looking for here in terms of identifying secondary cause as well? Renal disease is a possible cause. You'd look at elevated creatinines or reduced EGFR. Phacochromocytoma, we always got to mention it, even though it isn't that common, but I'm sure some of you have picked it up. Certainly, I've come across a case or two in my clinical practice. So we're looking for labile or postural hypertension, headache, palpitations, pallor, diaphoresis, i.e. unusual sweating. Renovascular hypertension, so hypokalemia, bruits, or significant rise in serum creatinine when starting an ACE or an A or B. Isolated hypokalemia, certainly you think about cause of hyperaldosteronism such as CONS, and certainly metanephrines, yes, in the diagnosis of, if we're talking about diagnosis, here we're just talking essentially about, in terms of FAO, about the presentation, but in terms of diagnosis, metanephrines are definitely the route to diagnosis. And then finally, Cushing's. I think we all know the clinical presentation of Cushing's. So and then there's a list of other possible identifiable causes of hypertension. Thyrotoxicosis is one. Obstructive sleep apnea, we got to consider coarctation of the aorta, acromegaly, and then also always consider medications, because we use these medications, the common ones that are associated with it, very frequently: OCP, NSAIDs, and even decongestants containing adrenaline and its derivatives. Just coming back to the idea of resistant hypertension, this is something we've done a little bit of work on recently, and actually the figures around resistance we certainly found in an Irish population, because it's always talked about as an issue, are lower than the international profiles that we'd come across. So we certainly found them in under 5% of cases, but they are certainly worth considering as part of our diagnosis. So a question to you. We'll get a little bit of interaction. Mr. P, considering all we've talked about, considering the data I've given you on him already, which of, and he can have one or more of these, do you think he has in terms of his diagnosis? Has he got stage 2? Has he got reduced renal function? Has he got stage 1 hypertension? Does he have any end organ damage? So anybody volunteer an answer on that?
Oh, no.
So I've got actually, I'm just getting a little bit of feedback from somebody there. So if you want to mute your mic, I don't know who's ever. Let me just have while we're waiting for those answers. Thanks. Thanks for that. Okay, so we're getting a bit of controversy here. So we've got stage 1, our both alluded to stage 1 or stage 2. No one's mentioning reduced renal function, which I agree with, and no one's mentioning end organ damage, which again I agree with, and no one has brought up. So the answer to that is, so I'm just bringing you back to his information there, but you didn't need a second look at it. It's actually stage 1 with no signs of end organ damage, and that's because his systolic blood pressure and diastolic blood pressure are between 130/40 and 80 and 90. So that gives him stage 1 hypertension. And we'll talk a little bit more about that in a second. So next question for you. what's our first ideas in terms of management? So should he receive lifestyle advice? And you can just say A, B, or C. Lifestyle advice. Should he receive an ACE plus lifestyle, or should he receive a calcium channel blocker plus lifestyle? So let's have a look here. Okay, so predominantly the majority of answers are A, and one person is answering B. So the answer here is A, and I suppose I would really like to make and when you look at the guidelines on this, it's encouraging that at least there is emphasis given around lifestyle advice, because lifestyle advice can be effective. I suppose that's the first thing. Now, we all know, okay, for sure, you know, a lot of this is essential hypertension. A lot of it is driven by genetics and age, and there's not a lot we can do about that, okay, for sure. But I think it's always worth bearing in mind, particularly because we're diagnosing this early in much earlier age groups now, to really try and hammer, particularly at that, you have a great opportunity, I think, at that moment you make diagnosis. That's the time you have a patient's attention in terms of a lifelong illness, the potential for lifelong medication. So I just reiterate to you again, just, you know, really try and hammer home the lifestyle message at that point. And I think it is appropriate in the context of what we're talking about here, where we don't have end organ damage, you know, to give this patient an opportunity around lifestyle advice. Okay, patients often fail, but certainly we all have had experience of patients who have succeeded, and they haven't just succeeded in terms of reducing their blood pressure, but often they've many other positive effects in terms of their overall health. So I really do think it's worth giving them the opportunity. So it is still the cornerstone of, you know, a cornerstone of lifestyle hypertension management, one way or the other. And we certainly should be using the moment of diagnosis to offer it. And then periodically, it's always important, I think, to, you know, when people are undergoing assessment and treatment, that we offer it again, or that we try and reiterate the importance of it. So what advice do we give Mr. P? We advise him to supplement his lifestyle with proper exercise and dietary changes, which would include salt intake, which is obviously important, and a low-calorie diet. And a useful rule of thumb I use with patients is that if they can get their weight down by 10%, their blood pressure often will drop by a similar amount, just to try and quantify it for patients. So in terms of this life, just drilling into it a bit more, I've mentioned the exercise issue about just making sure that we're talking about the same thing when we're talking about exercise to patients. It isn't just wandering around, it is activity at a certain intensity, and I suppose that's important. And the guidelines are 30 minutes over 5 days a week, or 5 days of the week. In terms of diet's always an interesting one, you know, and because there is so much controversy around diet, you know, and still remains a lot of controversy around the low fat versus the low carb stroke low sugar, if you like, philosophies around diet. My own, I mean, I think, you know, my own advice to people is very much around low carb, unless there's a reason to hone in on low fat, i.e. like a high cholesterol, because I think, you know, carbohydrates drive a lot of the behavior that we have associated with obesity. And certainly if you look at the data, which is becoming much more prominent now, it drives a lot of development of chronic disease as well. And, you know, in terms of the behavior, I suppose the other things that are a bit worth bearing in mind are issues like, well, you know, what advice can we give? You know, how do you simplify this thing? Because trying to sit down, I mean, we have only got 10 minutes for a consultation. I mean, I try and summarize the dietary advice into, you know, reducing quantity, first of all, and secondly, this idea of introducing maybe some protein early in the day. I mean, that there's good research around that, how that modifies satiety, modifies hunger. So that's another just simple things that I think you have to keep it simple for people when you're advising them about lifestyle. So where are we, Mr. P? Well, after a 3-month trial of lifestyle intervention, unfortunately, you know, it hasn't really made a great difference, and that's the case with a lot of people. I'm not saying it's a panacea, but I think it is worth trying. So his diet after 3 months still remains suboptimal. His BMI hasn't changed. And when we repeat his ABPM, we've now got a blood pressure of 145/80. So he's now moved into the stage 2 category. So now it's time to treat. So can I ask a question to you then? So what are we going to treat him with? Are we going to treat him with a calcium channel blocker? Are we going to treat him with B, an ACE or an A or B, or C, a thiazide diuretic? So if we get a little bit of feedback on that. So do we have some, we've changed our minds. Yeah, some people are saying A and now they're saying B, and other people are sticking to A. Okay, so how do we make the decision? Well, let's go on to the guidelines. Okay, I always use the ACDC is my new acronym for trying to remember this. So in terms of step 1, B is no longer, or D are no longer in step 1. That's the key change in the latest guidelines. Step 1 is either A or C. Okay, so we remember the old guideline was A and B on one side of the equation, C and D in the other, and you picked one out of those groups depending on number 1, age. So when someone's under 55 years of age, which Mr. P is, then A is the most appropriate first step. When someone is over 55 or they are of African American or Caribbean descent, then C is the most appropriate initial step. Whichever step you don't use then for step 1, you use that for step 2. Okay, so it's A or C first, depending on age and ethnicity, and then whichever one of those 2 steps you don't use in your those 2 medications you don't use in step 1, you use that in step 2. So step 2 invariably is A plus C, and then step 3 is A plus C plus D, and D being a thiazide diuretic. For resistant hypertension, which is defined as somebody who's on 3 or more agents without control, then you consider for the diuretic treatment, use of alpha blockers or use of beta blockers. And at that point in time, for that group who were resistant, that's probably the time to seek expert advice. So let's go on to changing landscapes. Okay, we've got about 20 minutes left. So in terms of changing landscapes, I suppose the biggest change in terms of the American College of Cardiology and the American Heart Association is this lower blood pressure targeting now, and really they're talking about now treating stage 1 as opposed to going straight to lifestyle advice, or at least doing it in combination. So that's something, I mean, NICE hasn't gone that way. So NICE still is, as we've talked about now, as we described, but this is something that may change, and you can see the compelling evidence around the potential for that. But also, I'm well aware that, you know, of iatrogenic illness, and I think the longer I go on, the more aware I am of iatrogenic illness. And certainly for older age groups, I think we have to be very careful that we're not treating people's blood pressure so low that they're suddenly starting to fall and fracture their hip. Okay, so there is a whole, you know, debate around that, which we could spend an hour on at least. So we don't have time to go into that, but I suppose there is that balance to be struck between going after targets and making sure that we're not causing extra illness, because, you know, primum non nocere, first do no harm. So we've talked about, alluded to this idea of the financial incentivization around ABPM, and I think that really has transformed the landscape in primary care and general practice in our ability with some resourcing to try and manage these patients better. And in fact, we're going to, it's a research question we're looking at is, you know, has this made a difference in terms of diagnosis and management, and eventually in terms of outcomes for patients in this country? And I think it will have. The last point, I suppose, is a systematic review, which I'm going to talk about in a little bit more detail, because the last area I just want to hone in on is this idea of, okay, besides the medication, what else can we do in terms of how we organize the care around these patients, and how we encourage the patients themselves to get involved in the management of their own illness. And this is what really this systematic review is looking at. But maybe let's start back with this challenge that I talked about at the start of the webinar, which is this idea around, you know, with all the medication that is available to us, and you know, with all the other things that are available, why hasn't our ability to manage our patients better, or at least achieve blood pressure goals in an increased proportion of our patients, why hasn't that changed over the last 40 years? This is a question I was asked to try and answer as part of an editorial I did for Annals of Internal Medicine recently, and hence the title of the talk. So maybe we'll first of all, let's try and answer that question. So why hasn't what is the data around why our ability to control blood pressure hasn't improved in the last 40 years? And I think it is down to what the literature refers to as the swamp of everyday clinical practice. Probably in the Irish context, that would be termed the bog of everyday clinical practice, where, there's lots of competing issues that are going on. We move from reading a guideline to sitting with a patient who's in front of you, who has multiple other illnesses, where the potential for polypharmacy and patient morbidity associated with that is a real challenge, and challenges not only our ability to manage the patient, but also challenges the adherence of the patient to the management plan that we might agree with them. I think one of the big challenges which I think is now changing is this idea of just reliable measurement and diagnosis. And I think the advent and the increased use of ABPM, and particularly the resources that we have now for that, hopefully will be a game changer. But when you do sit down with that patient, I suppose we've got to bear in mind that often we can be complicit in this whole idea of therapeutic nihilism between our patients and ourselves. And I suppose a study I'd really draw it to was a fascinating study done by Cannon in 2012, looked at, what is the incidence of new antihypertensive medication being initiated where there is documented uncontrolled hypertension. And unfortunately, that only happens in about a fifth of consultations. So there is something going on between us and our patients whereby we are not being activated, we're not being stimulated to make changes, or perhaps we're afraid to make changes, or perhaps our patients don't want to make changes. This is the bog of our swamp of everyday clinical practice where we're forced to make decisions, and it isn't easy. There's no straightforward answer to this, but I suppose I am hopeful that maybe there are some things that are changing that will help us do it better. I suppose that journey around this began with, I was involved in doing the Cochrane review in this area. So we were looking at the non-pharmacological interventions to control blood pressure. And we did this review some years ago. I was lucky enough to get a Cochrane fellowship to support me to this review, and I was delighted. I wasn't so delighted when we did our search strategy for the Cochrane review, and it spat out 10,000 papers at me. But anyway, that's an aside. So this is what the review looked like. We had just under 10,000 patients, and we ended up with 72 RCTs. And we looked at interventions. So the interventions I'm talking about, if you put the pharmacology to one side, the interventions I'm talking about are things like self-monitoring, like patient education, like physician education, like health professional-led care that wasn't physician-led care, so care led by a nurse or pharmacist. Then a big one, organizational interventions. So how do we structure the care within the practice to deliver that care better, and as part of that, appointment reminder systems. So we looked at outcomes: systolic blood pressure, diastolic blood pressure control, and the follow-up of patients in clinics. And it wasn't surprising. What helps patients get to target, or what helps us help patients get to target? But certainly self-monitoring is now, without doubt, has been shown quite clearly, and Richard McManus in Oxford's done a huge amount of work in this, to be definitely beneficial to patients and us in helping patients get to target. Nurse and pharmacist-led care is another area that's been shown to be helpful, and indeed appointment reminder systems, and particularly appointment reminder systems that are facilitated by newer technologies. So just in terms of just a quick forest plot, just so you're not freaked out when you see forest plots, this is a forest plot just looking at the intervention of self-monitoring around and its effect on systolic blood pressure. So each of these, if you like, each of these is a trial, and we took the data from each trial and we plotted it here in the forest plot, and then you put all that data together, and basically it gives you the outcome of the forest plot. And quite clearly, if the outcome here, which is the black triangle here at the bottom, if that resides on this side of the zero line, then we know that this intervention, self-monitoring, has a positive effect in terms of reducing systolic blood pressure. So that's just to explain a forest plot for you. And so out of our review, that certainly was a very strong message. But the strongest message out of the review came from this incredible study, which many of you will remember, which is the hypertension detection and follow-up program, which was actually done in the late 1970s into the 1980s. And I call this the forgotten RCT because I think it has incredible messages. I mean, what was it? Well, it was an intervention which provided rigorous and systematic antihypertensive care to 10,000 patients, which obviously half of those were control and half of those were the intervention group, who got, first of all, free care. So they got visits, they got medications, they got their investigations. It had big emphasis on them coming to clinic and adhering to their medication, and creating a convenience around that. And then there was a stepped protocol in terms of how patients were managed if they weren't achieving control, and also regular review. So this to me really sounds like how we should be designing our care around our hypertensive patients. It was there back in the 70s, and in many ways, and just to look at, so what effect did a program like this had? Well, it had significant reductions in systolic blood pressure, which you can see here, which were the three different strata entry groups into this trial were based on what their blood pressure was at entry, and all of the three strata had reductions in systolic and diastolic blood pressure after the intervention. And this reduction in blood pressure was so significant that it was quite clear that it was also reducing all-cause mortality, which was a significant reduction in all-cause mortality. So I'm quoting Albert Einstein here: insanity is doing the same thing over and over again, but expecting different results. So in many ways, I think we have been doing the same thing over and over again. We've also had a way of doing it in a different way. And I think we need to consider that, because this data really mirrors, and this here, actually, just if you want the forest plot for the hypertension, the HDFP study. So these are the HDFP studies here in the forest plot, and you can see the way they are driving really big reductions in the systolic blood pressure in this forest plot here. And really the message, so I'm now quoting the a systematic review from the Annals of Internal Medicine in 2017, which I was actually asked to write the editorial on. And it's exactly the same message in many ways. And this was, I suppose, the point I was making in the editorial, is the HDFP study gave us the same message. And that message was that when we look at the management of patients with high blood pressure, we look at it from two directions. One is we look at it from how we manage them, and the second is how they manage themselves. So these are, if you like, multi-level strategies at the level of the clinic, and then patient-level strategies, and both of them work. And when you put them together, they work even better. So it's the same message that's coming through, and I suppose that's what gives me a little bit of hope that we can transform the care of our hypertensive patients if we really engage with how we diagnose and monitor our patients. And particularly, I suppose I'm talking about our ABPMs, and I'm really delighted that the resourcing came in behind that, because that allows us the idea to get involved in this. I think we really need to encourage all our patients to get involved in the management of their own condition and responsibility for the lifestyle changes around that. But, you know, we know self-monitoring works, and this is something that we should be encouraging all our new hypertensive patients to get a monitor themselves. And when they do come and see you, that they have that data for you, whether it's Bluetoothed up to their iPhone, which a lot of them now are doing, or whether it's, you know, in the memory of their machine or written down. It doesn't matter, that they have that data for you, so you can make good shared decisions with them on it. And finally, I suppose maybe controversially, we need to look at ceding some of the control around the management of our hypertensive patients. I mean, to the allied healthcare professionals that work with us, particularly our nursing staff. You know, they are, when there's clear protocols for them to follow and clear treatment algorithms, they are really good at managing high blood pressure patients. I think we've done it, I think, in a lot of practices in terms of our management of our diabetic patients, and I think this is something we can also do. And I'm sure a lot of you are doing this already, but this is something that we need to consider. Finally, just a quick word about persuasive technologies, because I think the advent of, you know, hypertension apps or blood pressure apps on smartphones does give this, you know, we again have done a lot of work around this, and it's quite clear that people are engaging with this type of technology. It's made them change, you know, how they do their banking, how they book their flights, how they do their shopping. So I really feel that there's a space here where in terms of improving people's health, that that we've yet to engage with fully. So I certainly encourage, along with getting a self-monitor, I encourage my patients, if they've got a smartphone, to download an app as well. It has there's lots of different apps out there. They help people remember to take their tablets. They help people to record their blood pressures and give them nice graphics around that, so they know if they're doing well. There's not nice sort of stoplight systems, red for contact your GP, orange for you need to remeasure, or green for you're doing fine. So loads of different components of that, I think, hopefully can engender some movement towards behavior change. So I put some references in here for you to get stuck into, and these will be all up for you to look at if you want. And the final thing I'd like to say is thank you for the opportunity to talk to you today. I'm delighted to answer any other questions before you go. We've got about 5 minutes.
Okay, there's a question in the chat for you, Liam.
Yeah, so how does sorry, I'll read out the question maybe if everybody can't see it. How does the rising level of obesity in the community defray any foreseeable improvements in the reduction of hypertension prevalence? Yeah, I mean, look, this is really worrying. Obesity is a huge, it's a huge problem. And I don't know the answer to that question because the morbidity associated with obesity in terms of hypertension, in terms of diabetes, in terms of heart disease is really, really significant. I still, I'm not discouraged. I think, we need to use all the tools that we have that are available to us in terms of managing our hypertensive patients as best we can. But yeah, this is going to be a really significant issue. I think in the US at the moment, the current generation are the first that are going to die earlier than a previous generation. So a lot of this is driven by obesity. So, and it's a very difficult one because obesity again, and I'd love to give a webinar around that because it's an area of interest of mine. In terms of how do you get people to engage with behavior change around obesity? It's a very, very difficult one. But there are simple things we can do. And I'm sure everybody could share a success story around people who do engage and do manage small amounts of change over time and how that can have a transformative effect on their health. But yeah, I don't have the answer to that, but I suppose we're going to have to keep beavering away in terms of the hypertension question, and hopefully the improved tools we have around diagnosis and management, the improved issues that we have around adherence to medication, and hopefully the improved tools we have around patients taking control of their own health and doing some self-monitoring and self-management, particularly using persuasive technologies. Hopefully all these together will cause a step change in our ability to achieve blood pressure control. Okay, another question. How often should ABPM done in hypertensive patients in primary care? According to the latest guidelines, for somebody who has a diagnosis, it should be done annually. So this is the protocol we're following now. I mean, the other issue around, so that's just for, if you like, monitoring. I mean, I generally do ABPMs now when I change medication. So in terms of monitoring a response to a change in medication. So the three areas that I see as really important is, number one, a diagnosis, number two, a change of management, and number three, for an annual screening of hypertension. The next question from Kieran is there a role for organised care for hypertension, such as the diabetic cycle of care and heart watch, with suitable funding? I absolutely agree, Kieran. I think there's a huge argument for it. And it's so unfortunate in many ways that heart watch and the diabetic cycle of care haven't been replicated. I think there's a lot of really good things about them as well, but I think there's also a lot of things that could be changed around them as well. But to me, hypertension is the risk factor when you talk about global burden of disease. It's the risk factor. So if it is that important, then I think having, and we know now, the HDFP in the 70s and 80s, and Wills, which current systematic review in the Annals of Internal Medicine, same message. We need structured care, and if we do structured care around our hypertensive patients, it has a really significant effect in reducing blood pressure, and also eventually reducing mortality. So surely it's worth the investment, would be my argument. So next question is is there a raised and maybe this will be the last question then because I know probably you've got to get back to clinic and I'm conscious of time. So is there a raised blood pressure level where it's advised to consider starting with a combination agent? So this is an interesting question because this came up in the guidelines, and maybe that's where this question is coming from. You know, under what strategy should we be? You know, how do you decide the question between single agent? So if you say started someone on a single agent versus a combination agent. And I suppose the argument that we should be introducing combination agents earlier is a patient morbidity argument. So the idea is that if we have a single agent and we start to ramp up the dose, the chances of comorbidities associated with that a single agent have now been shown to be higher than if you use a combination agent at low dose. So the argument is for in those patients who have, now this isn't patients like Mr. P, who we've described, who are coming in at stage 1 or stage 2. This is stage 3 patients where you are, they've got markedly elevated levels. You're trying to get those levels down in reasonable amount of time, and you're not achieving that with a single agent. In the context of that, either in terms of where you're stepping up, rather than going to high doses of a single agent, the advice would be you first go to a combination dose of lower agents, or alternatively, in those patients who have significant levels of hypertension, starting with combination low dose is now being advocated. And one final question. A GP was recently castigated for not doing blood pressure in a child. Do you support our having all cuff sizes in a surgery? Yeah, I think it's very sensible to have all cuff sizes, and I wouldn't just talk about children in this context, but I think it's really important in terms of obese patients who we're seeing more and more of to have appropriate cuff sizes for that, or else we're running into areas of poor diagnosis. So. Thank you for all the questions. Thanks for all the interest. Thanks for your attendance, and thanks to the. And I'll let Martha finish off now, maybe.
Yes, thank you very much, Liam. That was a very great quality presentation. Thank you, and thanks to everyone who joined in for your incisive comments and interaction. So we will wrap it up now, as we're very conscious that it's people's lunch break. So I will just let you know that our next webinar is going to be held on Thursday, the 15th of March by Mark Murphy, and it will be on poorly controlled type 2 diabetes. So once again, thank you very much, Liam, and thanks to everyone for tuning in.
Delighted to be involved.
Thank you. Bye.